Good evening, everybody. We will start now with roundtable discussion, starting with the head of JSC, Jordan Society of Cardiology. JCS, Jordan Cardiology Society, Dr. Jamal Dabbas, a welcoming talk. Go ahead, Dr. Jamal.
Your Excellency, respected colleagues, and distinguished representatives. As the President of the Jordan Cardiac Society, it is both an honor and privilege to welcome you to this National Roundtable discussion. This gathering marks a critical step toward strengthening our collaborative efforts to enhance the care of patients with acute coronary syndrome in Jordan and beyond. The presence of key stakeholders from the Ministry of Health, Civil Defense, professional societies, and healthcare sectors underscores the importance of unified action. We are here today not only to align protocols, but to safeguard lives through timely decisions, evidence-based practice, and system-wide integration. Thank you for your dedication, and I look forward to a productive and impactful dialogue. Thank you.
Okay. It's a pleasure to welcome you again today on this roundtable discussion on enhancing the care of STEMI patients in Jordan. This is a critical topic with profound implications on the public health, patient outcomes, and healthcare systems. STEMI is amongst the most severe forms of heart disease, and every minute counts in saving lives and preserving heart function. While advances in cardiology have led to remarkable improvements globally, we recognize that there are still significant gaps to address, especially in the local context like ours. Today's discussion will explore 5 key areas. We start with Dr. Jamal Dabbas and the head of the JCS, Dr. Raed Lishboul, MOH representative, Ministry of Health, on the current landscape of STEMI care in Jordan. We will begin by grounding ourselves in the present. What systems are in place? What successes have we seen? And where are the pressure points, whether in early diagnosis, EMS activation, timely access to PCI, or coordination between facilities? So we will start with this. Dr. Jamal, you have the current landscape of STEMI care in Jordan, you and Dr. Lishboul.
Actually, I expect for every representative of healthcare sector to and for all of us to introduce themselves before and their role in this roundtable discussion. What about that, you think, Hanna?
Well, we have five areas. The first area, as we have discussed, is the current landscape of STEMI, that if neither you or Dr. Raed Lishboul have anything prepared, we can just make it a panel discussion because we have other 4 areas.
Dr. Raed is not with us. I think Dr. Anas Al-Muhtasib.
Okay.
Yeah, he is the manager of communicable diseases. Yes.
Okay, why don't we have the mic just going from one person to other to introduce ourselves here? Can we have the mic, guys? Mic.
مساء الخير. My name is Raed Aqil. I'm one of the private sector interventional cardiologists, and my goal and target was to work on STEMI patients in the ER, achieving the right protocol.
My name is Ayman Hamdan. I'm an interventional cardiologist in the private sector. I share the same goals with Dr. Ryan.
My name is Mohammed Mzayin. I'm AHA International Program Manager leading the Chest Pain Center Certification Program in MENA region.
My name is Yusuf Koussous. I'm a cardiologist.
Rami Khattar, the General Manager for the AHA office in the Middle East and North Africa.
Abdul Majid Zubaydi, intervention cardiologist from Abu Dhabi.
Hadi Abu Hantash, I was assigned in the task force with other colleagues for taking care of chest pain patients in the emergency room, and today I gave a presentation on the use of high sensitivity troponin for that particular sake.
Colonel Engineer Anwar Jdefat, Director of Ambulance and Humanitarian Support Department in Civil Defense Public Security Directorate.
Anas Al-Muhtasib, Director of Non-Communicable Diseases at the Ministry of Health.
Qais Al-Balbisi, Interventional Cardiologist, Chair of the Scientific Committee of the Jordan Cardiac Society.
Hani Nawafli, the Secretary General of the Jordanian Nursing Council.
Mohammed Al-Zabi, I'm an emergency medicine specialist, Ministry of Health, responsible for the emergency department training and pre-hospital training for trauma and non-trauma cases, and hospital administrations from the Ministry of Health as well.
Lieutenant Colonel Dr. Mamoun Harasha, Emergency Medicine Specialist from Royal Medical Services.
Zakaria Ammar, Head of Life and Medical Committee, Jordan Insurance Federation.
Ali Al-Halabi, Interventional Pediatric Cardiologist, Co-Chairman of the Scientific Committee.
Saira Madi, Chief Executive Officer for Technical Service at Healthcare Accreditation Council.
Yasir Musa, cardiologist of private sector, President of Jordan Atherosclerosis and Hypertension Society.
Mohanad Ababne, cardiologist and member of the chair of the Jordan Cardiac Society and at the Jordan University of Science and Technology.
Rashid Ibdah, cardiologist. I'm here to represent the university hospitals, and I was assigned to talk about the ACS at the community level. Shukran.
Hanna Al-Makhamra, JCS member, and we're here just to kind of put the grounds for this discussion on 5 different points. The first point is the current landscape of STEMI, where we are now. You know, this is probably the current scenario have been discussed unofficially or unofficially on different fronts, where we know that somebody who is close by to a hospital which provides the PCI capability is able to reach there. And we can't hide the financial burdens that some people cannot afford. أنا بعتذر إذا اللغة الإنجليزية للبعض عم تكون صعبة، بس لأنه عندنا ضيوف من أمريكا فأنا يعني أنا مستثقل إني أحكي باللغة الإنجليزية، بس الزملاء يعني من القطاعات المختلفة. فإحنا اللي بنحكيه هنا إنه the current landscape is suffering. So that's why we are trying with this initiative to bring out certain solutions to the current landscape. The current landscape, if you are not insured, you cannot be treated, simply. You have to go to an institution, a governmental institution, which may or may not provide you with the service that is required. And in this life-threatening condition, the service required is quite expensive and quite often is delayed, and we have problems with the transportation. As far as EMS, we have delays that I think lots of us have witnessed. We have quite incapable ambulances that are commonly seen to provide the services that is required. So the landscape is broad. This is talking Amman, Para Amman area. the areas that are distant are even suffering further. So we are here to discuss this. What can we bring to the current scenario? How can we solve the problems starting before, at the time when the patient has symptoms, and then how is he picked up from his place to an institution where his problem can be solved? I think the organization of the talk is going to be just whoever wants to speak can just raise their hand and we can start from there. Dr. Raed. Mike, please.
Thanks, Hannah, and welcome to our guests from the United States. أعزائي أصدقاء هون. I think the problem here in Jordan can be pinpointed to certain things that all of us do know. One, we have problem with education of the community. So my suggestion is to have programs on national TV, radio stations that will tell patients what's the meaning of chest pain and what they should do in case they had that chest pain. So education is number one. Number two, EMS services during transport. We need solid evidence that all of our ambulances are equipped with EKG at least and contact with ضابط الارتباط or the person in charge so we can have an early diagnosis before reaching any hospital. Transportation can be solved في عمان area in Amman if we use مسار الباص سريع التردد. That needs to be adopted. No way. Amman is very busy, crowded area. And unless we do that, we will achieve no saving in time. In terms of emergency rooms, we need very clear protocol, very simplified, posted in every emergency room. And then the post inside the hospital care, I think we are good at that, especially in Amman. And after that, the cardiac rehab we need to work on. Thank you.
Thank you, Dr. Raed. Anybody else would like to share their opinion? Dr. Zabi?
Regarding the Minister of Health capabilities for the PCI, we have already mentioned that the Minister of Health already have 6 capable hospitals that belongs to the Minister of Health, as well as the private sector that being included with the insurance for the patients. We also have in the north the King Abdullah University Hospital, which covers for the PCI if needed. The thing that worth mentioning is that we do have an ongoing national classification for all the hospitals in Jordan, as we said. Based on that classification, whether it was public hospital, government, public hospital or private hospital, or even the Royal Medical Services, that will not stop the patient from getting the treatment. It will be connected with the civil defense to guide the civil defense EMS services to which hospital to go under the Ministry of Health administration and guidance through the telemedicine. If he needs a stroke unit, he goes to stroke unit. If he goes to, needs a PCI, he goes to the PCI. But we don't have a clear classification of which hospital has what as a nationwide guidelines, but the Minister of Health is working on that through the Crisis Management Administration. The other thing that I wanted to mention on behalf of the Civil Defense, I know they have their own opinion on that. Every telemedicine vehicle of the Civil Defense do have the ECG machine, and they do have the EKGs, and they do contact the telemedicine regarding that patient. Solid evidence, I think it's something that's being done, so we can have the data from the Civil Defense regarding that issue. The transportation as well, I agree. The path for the rapid transport of Amman, that's something that should be used at least after the working hours of the bus. So that is something logistic. I think the Civil Defense and the Minister of Interior should be involved on that case.
Yes, please, Doctora.
I will talk from the quality perspective. I think the most important challenge here in Jordan is standardization. To have a standardized protocol especially for stratification, risk stratification. I know you are all physicians and know more than me that it is the second cause for admission and for asking or seeking for medical assist. So most of the cases is low risk. So if we have a standardized way to risk stratified and identify the life-saving condition in order to provide the timely treatment and intervention, and also this will help us in the optimization, resource optimization, to not overuse of resources, diagnostic procedure, or admission, or even discharge the patient who are in need. So from quality perspective, I think we need a standardized way. This will help us to mitigate any misdiagnosis. This will help us to find the data, and this data will help us to improve our service and save the patient. Thank you.
في حد تاني حاب يشارك؟ تفضل دكتور مهند. دكتور إياس تفضل.
شكرا. I discussed some of the issues about the paramedics مع أنور بيك before, and I think it's very promising that we are seeing defibrillators everywhere, because I think that's a very important point. And a roundtable discussion sometimes can come out with vague resolutions and decisions. I think the more we keep it simple and straightforward, the more we can have practical recommendation, because we will need to recommend to the Ministry of Health, to the Parliament, to the Emergency Department, what is out of this day. We've been here since 9 in the morning. So you have to come up with a conclusion that we recommend 1, 2, 3, 4. And I think we need to suggest that we need to recommend that the Minister of Health reinstitute the Stent for Life initiative that was solving a significant problem of the STEMI coverage in the private sector, until we make sure that the network of the 6 hospitals in the MOH is capable of covering the whole kingdom. We need to focus more on out of Amman places. I still think in Amman you would get a reasonable treatment, but in many places I'm not sure the connectivity. So we need to look at that carefully. A third point, I think I'm not sure about Al-Bashir PCI capabilities. I would like to ask Dr. Zorbi to comment. Are they doing PCI 8 to 4 or 24/7? Because that's a very important point. I think Hamza is covered, the Bashir, and the private is ready. The private hospitals they can staff and equip themselves. I think we need to push towards Bashir becoming a 24/7 primary PCI. I think if we come up with 3 things, a 24-hour coverage in East Amman by Bashir PCI, a defibrillator for each ambulance and people who won't die in transit, and the education Dr. Raed talked about, we will have a significant stride in this direction. The less we have, 5, 6 decisions, our recommendation that are practical, better than 20 or 30 that will be more,
Dr. Muhannad.
Just one additional point to mention, because Dr. Raed mentioned this, the adherence and the compliance of the patients and their understanding about the disease. One major issue we have is the question of the costs. We have very different kinds of insurances or not insured patients, and that's one main problem in what's regarding the compliance or adherence to treatment, the access to a treatment, and that the patient sticks to their medication afterward, the primary treatment. I think we have here to come with a clear statement and to find somehow kind of agreement between the different cost triggers.
Thank you. Dr. Qais?
Yeah, sorry, if I might suggest a way to kind of structure it, because as you said, we can go through the round table a long time, and we need to kind of focus and make sure that these are the recommendations that we want. How about we follow the journey of the patient, as we did today? Each one of us had a task, and they start with what they feel while they went through the literature and the deficiencies and the challenges, because each part of our task teams did that, and suggest these are the things, these are the big challenges, and we think this might help. And we vote amongst us whether it's good, bad, it's high priority or low, and then move forward to the next part of the journey. So we start from, when they're right at home, then we go to the ER, then we go to the inpatient and post-care. This way it's structured, and we tackle the challenges and vote on them and move forward. What do you think?
Well, I believe, Dr. Qais, a couple of points have been mentioned already. The education of the patient through the media, that's something that everybody agrees on. And the second point in regard to transportation, the EMS system and the suggestions that have been put together now, and the reassurance from Dr. Zuabi that some ambulances, or most of them, have ECG, but we need the defibrillator, as Dr. Iyas said. What's left, I think, is the timetable to achieve the 8 minutes, as Dr. Ayman said earlier in the morning, to achieve an 8-minute arrival to the patient. But the access points through الباص السريع or you name it is something to be discussed with the authorities in that regard. Please.
Okay. So, sorry. Yeah, you wanted to go. Dr. Rashid also, he had a big role in looking at the patients at the beginning of his journey. Go ahead, Dr. Rashid, please.
Okay, thank you. I think at community level we have 2 points to address. First one, and these 2 points are very vital to save lives and to enhance our care for individuals with chest pain. The first one, we have to focus about the importance of seeking medical attention or medical care early by individual or by patients who complaining of chest pain. This can be achieved by recognized by community, by people, recognize the symptoms of angina or acute coronary syndrome, and by knowing the alarming symptoms, and this can be achieved by campaign, the social media, TV, universities, and other sources of knowledge for population. The next point is focusing about the transport logistics. After seeking medical attention, how to deliver the patient to the right place in the right manner and in the timely manner. So I think we have the الدفاع المدني بجوز هو اللي بالأردن يعني بجوز اللي major transportation our patients. We have to shorten the arrival time from the home to the proper hospital, and to يعني نتأكد إنه الأمبولانسز زي ما حكى أنور بيك إنه فيها ديفيبريليترز، وإنه الديفيبريليترز هذول بيستخدموا مش بس موجودين. إذا في كمان داتا من أنور بيك إنه في استخدامات للديفيبريليترز during transportations، أو إذا في أي داتا بتحكي عن ال ACS during transportation. ف يعني ضروري جدا إنه الباراميديكس be capable to perform a high quality CPR for patient who needs. I think these 2 points should be addressed and focus on these points. Thank you.
Dr. Mustafa. Sorry, Dr. Anas, عفوا منك.
مش مشكلة.
You're ahead. Go ahead, Dr. Anas. بعدين Dr. Mustafa.
Okay, thank you so much for inviting me for this an important roundtable discussion. Actually, I'm director of Non-Communicable Disease Directorate. At the same time, I'm director of UHC plan that the Prime Minister announced several months ago. I want to comment on maybe 4 points, main points. I think, yes, maybe some of our colleagues from the Ministry of Health didn't attend this meeting, but I think maybe we need to invite more people from Ministry of Health to attend such important meetings, because the Minister of Health is the main provider of healthcare in Jordan, and their involvement, their taking responsibility for this part, I think they should be more involved in these discussions. Anyway, thank you so much. One important pillar is to have the primary health care and to provide the services through the primary health care centers who can make the education for patients, who can make the early emergency treatment before the coming of the ambulances. And this really important to be addressed and to be used and as the first access for the healthcare. Another point, I maybe mentioned this several times to Dr. Jamal in the calls before, that to have these recommendations to be translated into actions, we have to have this leader who can take responsibility to translate these recommendations into practice. And this leadership should be at the Minister of Health. My convention should be under my directorate, then this is my responsibility. I addressed that, and I think I need your advocacy. Yes, I'm asking for your advocacy to make pressure on to have more and more, and I have shortage in cadre on workers and public health officers who are able to translate these recommendations into actions. And I think this is a very important recommendation that we have to support in this regard. Finally, I want to comment about the UHC plan. UHC plan now will look to expand the mandatory health insurance to those to another new scheme, as the Prime Minister mentioned. But then, at one moment, the first phase should focusing on the primary health care. But after that, it will focus on the secondary care, including this. Then the issue of that insurance is not covering or not, of this problem of coverage should be solved. And I hope you make another also advocacy in this regard, because we find several advocacies regarding, for example, cancer. And for sure, MI is much more important and much more urgent than cancer. And PCI is much more cost-effective than many of cancer treatments. So I hope that your advocacy reach to higher levels to advocate for this, to make pressure to this, to make this coverage for those people, and to try to cover those people as possible as we can. Thank you so much.
Thank you, Dr. Anas. Dr. Mustafa?
We have seen that PCI is the main state treatment for STEMI. We have seen that in cases where the expected time is more than 120, we have to give thrombolysis, then we have to transfer patients. We talked about the impact of delay in transport on mortality. I see that we have some defective points. If we address, we can reach to a more perfect way, or let's say more perfect way to address these issues. It's unacceptable to give thrombolysis in a center where the PCI facility is available. It's not acceptable to have somebody with a STEMI and not to receive the proper treatment because he's not insured.
Yeah.
It's not acceptable to have your patient on the time and to wait for 1 hour until you receive approval from the insurance company to give approval, and to lose the time, the precious time for the patient where we have to achieve reperfusion. I think we have to solve these issues.
Okay.
Because these issues, if we succeed to go out of this conference with recommendations that address these issues, I think that we will reach the perfect way
Thank you, Dr. Mustafa.
dreaming of.
Thank you. If you guys allow me, Dr. Jamal, we would like to have the contribution from our colleagues in the US. We'll then broaden the lens to consider international best practices in STEMI systems of care, from well-integrated networks to time-to-treatment protocols in the US. We'll look at this working elsewhere and consider how these practices might be adopted at Jordan's unique healthcare infrastructure. Dr. Suresh and Dr. Unaya, please.
Thank you, everybody. So first, I'm honored and humbled to be in front of all of you and to help the Kingdom of Jordan come up with a methodology of systems of care. So it's an excellent discussion so far. So just a few points. If you look at the care of the patients in the Kingdom of Jordan, for a minute, I want you to not look at how we do things in America, but to come up with the Jordanian system of care. That's what the AHA is trying to help the people of Jordan, or the cardiologists in Jordan and the Ministry of Health, to come up with a methodology. We and the International Committee of the AHA, we are currently in 13 countries, and every one of the things you spoke about is spoken in each of the countries in terms of cost of care, in terms of how every part of Jordan may have some variations of care. So the reason why systems of care is important is, for a minute, you got to separate how we manage patients with chest pain to how we manage patients with STEMI. So for a minute, take away STEMI, but look at the overall patient who comes into any hospital in the kingdom with chest pain. So the people of Jordan, the patients in Jordan, first, how do we educate them? How do we involve the community practices? How do we involve various people to educate them in terms of what happens when you have chest pain? Secondly, what we have to do is then look at the pre-hospital care, which means the ambulance systems, and how do we get the patients to the hospital as soon as possible. And after that, once we establish the pre-hospital care, then you move to the inpatient care. What are the processes? What are the protocols? Forget for a minute what PCI has done. I'm sure there are excellent cardiologists in Jordan. Two of my partners are Jordanians, and they are amazing technically. The idea is not what we do in the cath lab. The idea is, after the PCI, what happens to the patient, and finally what happens to the patient in the post-acute care. So systems of care is really this whole concept of the patient in the community, pre-hospital care, in-hospital care, and post-acute care. Those are the ways how you can look at it in terms of how we manage our patients. Can I have my first slide? Josh, do you know? Rami or Mohammed?
Well, should we share the slides from our side, or? We can do it. We can share, if that's okay.
Yeah, let's go for it, Josh. So let me keep talking. So I heard during the discussion of all the ways by which a patient with chest pain can be managed. Josh, the next slide. So most of you spoke about some of these things when you were all talking about, how do we come up with a methodology within Amman, not only in Amman, but in the areas around Amman? And what do we do for the people who live far away from Amman? How can we also help them? So how do we develop various methodologies? Most of the cardiologists in the room already know this, that when you do a patient, when the patient comes in to the hospital, there are two ways of broadly looking at it. One is for a patient who comes to a hospital where you can do angioplasty and stents, or to another hospital where a patient cannot have angioplasty of stents. For 1 minute, I want you to forget about the cost of care and just look at the managing the patient before the patient gets an angiogram. You know, when did the patient come to the hospital? How many minutes did it take for the patient to get an EKG? After the patient gets the EKG, what are the other medications the patient got? Then the patient came to the cath lab, and then we did in the procedures in the cath lab. After that, how do you manage the patient? Those are some of the things I want you, all of you, to think. This is a schematic which just says in the US and in most parts of the world, the idea is if a patient can come to the cath lab and an artery can be opened before 90 minutes. So first medical contact to opening the artery. It's no more door to balloon. The idea is from the community or from the time the patient has symptoms till we open the artery. Can you do it at 90 minutes? This is in hospitals in Amman where they have a cath lab. And in hospitals that they don't have a cath lab outside of Amman, can we have a methodology by which these patients can be transferred to a center within 120 minutes? Those are the numbers that we use. So within 2 hours, can you send a patient from inside Amman or outside Amman to a hospital where they can have angioplasty and stents? Then that would be the best approach. Josh, next slide. So really, I briefly spoke to you about, the patient, the people that we take care of. They are unfamiliar with the symptoms of heart attack. Most of you know men and women present with different symptoms. So how do we educate not just the men, but also the women in Amman and in Jordan? And how can we involve the primary care physicians in educating people? And people mentioned about TV and media, social media, all of it, to develop a Jordanian method to teach them that when you have symptoms, how can you go to the hospital and how can we manage them? A lot of people don't think it's a heart attack, so the denial is a big part of it. So how do we get them to do that? And then how do we activate a system, an EMS system in Jordan, and try the level best if a patient cannot come by ambulance? We try and tell people as much as possible not to come by car, because 1 in 3 patients with a heart attack still dies at home. So the idea is patients still die at home. Can you develop a system of care to bring the patient to the hospital? And finally, in the hospital, how do we identify these patients? What are the protocols that in Jordan, you can come up with protocols and policies that can be followed across the whole healthcare network with the help of the Ministry of Health and all the physicians there and the Jordan Cardiac Society? And finally, how do the hospitals accept these patients? And what is the condition of the patient when he comes? Because some patients are very sick. How do we manage a really sick patient versus how do we manage a patient who's less sick? And then all of us know transport is not easy. There are problems, you don't get ambulance, there's weather problems, there are various, difference of care in the transport. So that's something that you have to look at. And finally, in the receiving center, how do we accept the patient? How does the cath lab team work? And how do we manage the patient? Next. So some of these things have been mentioned by the people in the audience. You know, what is the distance to the hospital? How do we bring the patient? What is the weather? What is the geography? What is the traffic? Because sometimes inside Amman, the traffic may be very, very high. So how do they come to the hospital? Finally, what is the awareness of the public? Not only that, you know, there are private hospitals, there are public hospitals, there are military hospitals, you know, and then people mentioned insured patients, non-insured patients. How do we come up with methodologies to help all of them provide the best care possible? And hopefully once you develop a system of care within Jordan, then with the help of the Ministry of Health, you can come up with some kind of resources that can be used across the system of care to help as many people with chest pain get the best possible care. You know, most of us in the audience who are cardiologists, all of us think that the care we provide is the best care. But if we actually look at our own data and start looking at how our hospital patients are managed, you would be surprised at how all our patients get differing cares. So I would venture to say that in the best hospital in Jordan, if you go and look at your system of care, 1/3 of patients will get excellent care. 1/3 of patients will get care, sort of standard of care, but it could be better. And 1/3 of patients, for some reason or the other, even in the best centers, they don't get the appropriate care. When you really develop a system of care in Jordan, those numbers will shift. And can most patients coming to Jordan get 8 out of 10 things that a patient with chest pain should get before even going to angioplasty and stents? That should be the method of how we can do it. And then if we are lucky enough, somebody is able to come to the hospital soon, they get the best standard of care, then you have really translated care in the kingdom in terms of getting the best possible strategies possible. And I think there was a lady in the audience who mentioned about quality improvement programs and the data that is important. So when we partner with the AHA, you will have the Jordanian patients in a Jordanian data that you can look and develop a quality improvement program that really looked at the data in hospitals, not just in Amman, but in hospital across the kingdom, that you can look at it and you can improve the care of the patients that come to the hospitals. So next. So really, what are the keys to a successful STEMI referral network? We call it as Mission Lifeline in the US. You could call different kind of a name in Jordan, where you create a lifeline, a Jordanian lifeline of care for STEMI systems, or you can call it a Jordanian lifeline for chest pain, where you create a map of the referral network and you come up with treatment options based on the region that they are in. So for Amman, you come up with a system of care. For the people just a little bit outside Amman, you can have one level of care. And then for the people who live far away from Amman, how do we help all of them? So, you know, you have receiving centers, how do we manage them? You have referral hospitals, how do we manage them? And how do we help not just the cardiologist and the emergency room physicians, but also hospital administration? Who are the nurses? Who are the nursing supervisors? Who are the people who bring the patients from the emergency room to the cath lab? So all of that can be looked at together in terms of helping the best possible care to the patient, you know, and we set benchmark and goals within the Kingdom of Jordan in each of the hospitals and come up with quality metrics, you know, and you have a common data source. Everybody in the kingdom enters a similar kind of a paperwork. or a network that you establish, so then you can look at each of the systems of care within Jordan that you can then every 3-6 months to a year from now, how can the kingdom have a different level of care than what we are in 2025? Then you will really help the people there in the kingdom in terms of how chest pain is managed. Next. So this is just, I live in the center of the US in the state of Kentucky or the Commonwealth of Kentucky. This is, where I work in a large healthcare system, 2 to 3 million people, small hospitals, big hospitals. If you drive 25 minutes from Cincinnati, you're in the middle of nowhere, and people that are small hospitals, how do we bring all of them to a bigger network? So you have the public or the patients, how do we teach them? Then you have the patient, and how do they call 911? How is the ambulance involved? Then how do they come to the hospital? And how are all the health agencies working? How is the insurance companies working with it? And how is the government? So with the help of the state government in Kentucky, with the help of, the AHA and the national things, we have now systems of care in our whole state to help as many people as possible come up with, real methods. And we can clearly say that between hospitals that are certified and hospitals that are not certified, you actually will show that there's a mortality difference. And I'll show you more slides to say close to 35 to 50% of patients will have a better outcome once we develop a Jordanian system of care in terms of managing patients with chest pain. Next. So this is just a map of Amman, and you can see that in Amman there are, right now 3 certified centers. So how can we develop multiple, I would love in the next year, we have 3+ marks there. So can you have 10+ marks, and pretty soon in a year or two, can you have 20, 30, 50, hospitals that are all certified and all of them are connected, and you get a regional system of care within the Kingdom of Jordan working with the Ministry of Health. And that would be an amazing thing for all of you to develop with the help of the AHA and with all of you in the room. I am sure you can do it. We are there to help you accomplish that. Next. So if you look at the standardized protocol for treatment, we have same policies, same protocols that every patient with chest pain that comes, we do close to, in my system, we probably do 1,800 interventions. We do close to maybe 20 STEMIs per month, so about 250 STEMIs in the hospital. So every patient that comes has the same level of care from the time the patient comes to the hospital. There are 10 interventional cardiologists. Each of us may do something different in the cath lab. But what happens before the patient comes to the cath lab, after the patient goes from the cath lab, is pretty much the same. And can we develop that in a Jordanian way would be the way how we can do this. So how do we register a patient with chest pain? Within the first few minutes, if a patient has chest pain, can you move that patient in a slightly different way? Get an EKG within 5 to 10 minutes, figure out the registration with the help of the family later. Then if the patient's in the triage, immediately you get a quick history. How can we get the ECG or EKG to the physician who's there? The ED physician immediately calls the cardiologist. As soon as we know it's a STEMI, you bypass the whole system and you come to the cath lab. How can you develop a system of care? And then in the emergency room, what are the labs you get? You get 2 IVs. Hopefully, most of us do radial interventions now. We don't put IVs in the right arm anymore. You get an IV in a different arm, so that simple things like that, you map it out.
Dr. Suresh?
Every system, yes.
Sorry to interrupt you. We'd like to have you longer, and we will have you for the panel discussion. I'm not sure how long is going to be your presentation, but you know, it's a bit late, and the panels have been here since 8 a.m. Our time, 8 a.m. Now it's around 7 p.m. So it's 11 hours.
Okay. Give me about 3 minutes. I'll finish up.
Okay,
Josh.
sounds good. Sounds good. Okay.
Josh, can you go to the next? Go to the next one. Next. I can send you these slides so all of you can have this the slides. So go to the next one, Josh. I think I mentioned institutional and regional. Next. Okay. So thank you so much for for having me there today.
No, we'd like to have you. We'd like to have you
Yeah,
longer.
I'm going to spend the next hour with all of you.
Yes,
And,
yes, that would be
talk
great.
through- the one thing I'll tell you is we are doing the same systems of care in India now. We just certified the first 2 hospitals in India, in northern India and southern India for stroke. We are certifying hospitals in India for chest pain. Later this year, there would be 4 pilot hospitals. We have certified hospitals in Abu Dhabi, in Dubai. We are certifying hospitals. I just came from Japan 2 weeks ago from the Japanese Circulation Society. We're doing heart failure certification for 5 hospitals in Japan. The idea is not the AHA, but the Jordanian Cardiac Society, the Ministry of Health in Jordan, and the people of Jordan. How do you come up with your own method? That would be the way to go. Thank you again. I'll stop here, and if somebody has questions, or we'll keep talking together. So, thank you.
Thank you, Dr. Suresh. Dr. Qais, I think we are left with the take-home messages for the things that we have talked about, and then after the ER, I think it's a straightforward process. So if you can just take us through what we have done so far. تفضل أستاذ. تفضل باشا تفضل.
At the beginning, I highly value this session, okay? And I would to take that all points mentioned are implemented through applied protocol, which closely adhesive with AHA recommendation.
Yes.
Okay? And I would like to confirm that all ambulance have advanced device, okay? Included اللي هو DFib and AED.
Thank you.
And our civil defense stations or centers spread on all the kingdom, okay? And they, sorry, and they are work in the same, let's say, standards for all the cases, okay? And to have the response time, we have 7.5 minutes, okay, the response time for our ambulance vehicle, okay? It's closely to the world response time, or maybe less response time. And we work to enter many services to reduce this response time, like launching bike, EMS bike, which is reduced the response time, and dealing with many cases, emergency cases. So all things that's mentioned in this session, let me give me
Sure, go ahead, take
2
your
minutes,
time.
3
Take your
minutes,
time.
a mic with my colleague to give you the steps that we are working in civil defense to be clear about the EMS, okay?
Thank you, please. Yes, please. Yes, please.
At the beginning, thank you to give me the chance to clarify clearly the 5 crucial steps that we adherently follow by Jordanian civil defense paramedic. If we are treating with a chest pain patient, we have a systematic approach in 5 stages. At the beginning, dispatch and pre-response phase. We are receiving calls from National Unified 911 Emergency Dispatch. And in these states, we collect the crucial information from the patient or from relatives, and at the same time giving the fundamental medical advice until reaching a paramedic the scene. So there's a lot of questions to ask the patient or relevant, and to give them first aid remote instructions to increase the survival rate. After this stage, there's a lot of on-scene assessment at the beginning when the paramedic or ambulance reaching the patient. And all the procedures, it's closely adherent to American Heart Association updates and the systematic approach at the beginning with the primary survey and focused history, and even initiating a 12-lead ECG. To be honest with you, every paramedics in our Jordanian civil defense, it's closely treating all the chest pain cases as a cardio causes until proven otherwise. Okay, so we initiating 12-lead ECGs and collecting a focused history, and there's an immediate intervention needs, we will provide at this station. After contacting with medical direction, we called Midyaf. Okay, there's a lot of medical doctor at this room. There's take transport decisions. Where's the suitable facilities? It's suitable for this patient. According to distance and according to time sensitive, that patient will suffering from these cases. And if we are talking about en route care and ongoing treatment and assessment, there's a continuous monitoring, and these crucial data, such as 12-lead ECGs, pulse ox, blood pressure, and so on, all these crucial information, it's transmitted to the medical doctor and the dispatch, and this medical direction maybe give a medical order for sometimes life-saving medication and interventions such as electrical therapy, if a patient need, and treat a complication during en route to the hospital. And the final stage, there's a systematic also approach when we hand off the patient to the facilities and to continue the medical procedures that will established in the ambulance. And there's a follow-up procedures that we are closely adherent. There's a lot of focal point paramedics, officers in the emergency department to follow up these patients. And thank you for giving me this chance. And all specific steps that I mentioned before, it's well documented in a national pre-hospital emergency response system protocol. It's a unified protocols. Thank you so much.
Thank you so much. And if I might say, I'm very, very proud. This is truly amazing work, and it is very heartwarming to know that that's already happening. And one key point is we do not want to reinvent the wheel. We want to build. We don't want to, go from point zero. And clearly, it's very systematic, and it's an amazing job. And I would say our one big suggestion I would say is right now we need to build on this. This is already there. We do not have to reinvent it. So maybe we should emphasize and make a recommendation that the preferred method of transport for any sick patient with chest pain is civil defense, because that's probably the safest, most efficient, and it can take it to the next step. Now, we have to work with the Ministry of Health on improving or on completing because you're already doing the job, the referral network, and how can we as Jordan Cardiac Society and different sectors help make that job and task easier. So I would think this particular part is completed. There are two comments, so I want to hear about the comments, so please go ahead.
Okay. Actually, we are for the pre-hospital protocol. We are fully prepared to support civil service, civil defense service, the provision starting with 24-hour consultation service for the civil defense teams. This includes integrating their on-duty physician into communication network with cardiologists across Jordan, allowing for immediate consultation whenever needed. This is our offer actually from the Jordan Cardiac Society. Besides, concerning the availability of 24-hour PCI capable protocols for STEMI patients in public sector, it is not satisfactory, or at least I am not satisfied with the fact that there are currently only 2 centers that provide the service in the public sector. One at Jordan University Hospital, 24-hour service, PCI. The other just in King Hussein Medical Center, 1 center in the Royal Medical Services. Private sector, it is open 24-hour for all hospitals that have cath lab. For that thing, I think we can do many things to ensure key recommendations that we can emphasize. First, we have to emphasize, adopt a unified national protocol for the management of acute coronary syndrome in Jordan. Second, to perform an ECG within the first 10 minutes of initial contact. Third, do not delay STEMI activation or cath lab referral while awaiting troponin results. 4, ensure the presence of defibrillator during any internal transfer of ACS patients. 5, repeat ECG with every 10 to 30 minutes if chest pain persists or changes. 6, implement an administrative fast-track system for timely inter-facility transfers. 7, reactivate the LIFE network, as Dr. Iyas mentioned, project as a LIFE network stent project as a practical framework for time-sensitive ACS care. 8, ensure the initial ECG is performed within 10 minutes, as I mentioned. In that respect, I think what we can do and offer in the JCS, we are fully ready to assess in implementing an operational framework of the LIFE network in all areas with PCI-capable centers across the kingdom. This would involve coordinating the availability of cardiologists through the existing on-call service system already in place within the Ministry of Health. This is just a small note that I want to notify from my notes I finished.
Dr. Jamal, just 2 hospitals, I think they are also on the list. King Abdullah University Hospital at Jordan University of Science and Technology, Dr. Rashid, Dr. Muhannad are part of the team that are activated 24/7. And also Prince Hamza Hospital.
Now Prince Hamza is what?
Prince Hamza is I think part-timers are doing the 24/7.
I hear just maybe, yes, King Abdullah in the north and Jordan University and King Hussein Medical Center, all that I know. I asked just before maybe 1 month for this fact, and I was really surprised about it.
About Prince Hamza?
Salt, no. When? Are you sure? But when, if you are sure? Bashir, no, they told us they don't have like this. So, no, we don't need the threshold. There is no threshold to make, for STEMI patients, it should be allowed directly. Yeah, we have doctors, we have cardiologists in Jordan, we can supply, we can aid in this matter. why not to work for the life?
Dr.
STEM.
Iyas, Dr. Iyas, then Dr. Hadi, and then Dr. Hani. Sorry.
أنا بس عندي كان two comments بالنسبة لل emergency medical services. The emergency bikes, what are they exactly used for? The motorcycles?
عندنا 11 بايك موجودات يعني في كل المملكه، عندنا 5 داخل عمان عاصمه عمان، تمام؟ وموجود 2 بالعقبه و2 بالشمال موجود موزعه. هي موجوده في نقاط ثبات، في اوقات الذروه، في الرش اور زي في اوقات الذروه واوقات الزمن، يعني مثلا خلينا نحكي دوار الشهر من الساعه 8 للساعه 3 في دراجه اسعاف موجود عليها شخص مسعف، تمام؟ وموجود معه صندوق، موجود فيه حتى الاي دي، موجود فيه اللي هو ديفل، موجود معه يعني الاجهزه كامله المعدات مركوبه كامله بالصندوق، تمام؟ مجرد ما اجى خبر انه في حادث او في حاله معينه يتحرك، وبنفس الوقت تتحرك سياره الاسعاف. تمام؟ تتحرك سياره الاسعاف، لان مجرد ما وصلوا وجود دقيقتين 3 دقائق سياره الاسعاف بعد دقيقتين 3 دقائق توصل. فهو يكون عمل الفيرست ايد له وانهى الموضوع وجهز، الان اذا كان حاجه الى نقل مباشره سياره الاسعاف توصل، اذا كان بحاجه الى اي شيء ثاني. فهي يعني الحمد لله الخدمه يعني انطلقت يعني لاقت صدى كبير وعملت كثير في تقليل زمن الاستجابه في الموضوع، يعني نحكي خلال شهرين 11 دراجه، يعني احنا بلشنا بدراجتين بعدين توسعنا لقدام ان شاء الله راح يكون في وسايق دراجه مسعف.
Excellent point. Point then, do you reach people by GPS location or they have to describe the streets and the
الان شغالين في النظام مع وزاره الاقتصاد الرقمي ان شاء الله، يعني شغالين عليه، واذا يعني وزاره الاقتصاد الرقمي تشتغل عليه، من كل سياره عندنا فيها GPS، وهذا متطلب من متطلبات الCAC، لازم يكون في GPS. بس حلينا معهم الان موجود هاتف خلوي موجود في كل سياره اسعاف، يتم اللي هو مباشره مجرد ما تواصل مع الشخص يبعث اللوكيشن للشخص واقرب مسافه يتجه باتجاهها. يعني احنا ندخل على المعايير اللي احنا اشتغلناها مع مجلس ائتمان المؤسسات الصحيه والتنظيم العالميه، يعني جماعتكم معنا يعني 9 مجموعات 73 معيار، وعملنا اتوقع 78 معيار، يعني من الابره للاكبر شيء بالكذا، يعني في كل شيء، في كل اي شيء يخطر على بالك في خدمه بري هوسبيتال كير حققناها واشتغلنا عليها، والامور يعني الحمد لله. حتى من ناحيه التعقيد، تطهير سياره الاسعاف، الملابس، ايش يوكل المسعف؟ المسعف ايش يوكل؟ يعني شو طعام يتراقب عليه، لانه هذا تخلص من النفايات الطبيه، هذا شيء ضروري.
ايش يوكل المسعف؟
المسعف وين مكان نومه؟ وين مكان لا هو جزء من العمليه، هو جزء من العمليه، فبالتالي لازم وين، فبالتالي الحمد لله يعني يجوز خدمه الدفاع، خدمه الاسعاف الدفاع المدني يعني حققت شيء كبير، وان شاء الله انه احنا مستمر في هذا الشيء.
Thank you very much for this great conference. Really, there's a lot of things coming out from this day. It's really very rich. In regard to the Jordanian Nursing Council, what we are doing and what we are looking forward. You know, if you got a top cardiologist and you don't have a smart nurse with you, there's a lot of defect will happen. That's one. We need also to include the nurses in all the plan to be all. We need capacity building to the health team members. Yes, I agree. We got a great cardiologist in Jordan, but still we need to have capacity building to the other health team members. We need also to focus on the peripheral areas. Peripheral hospital, yes, the Ministry of Health and the Royal Medical Service, they are doing a great job, but still we need also in these areas to have the telecommunications for the ECG interpretations, because sometimes there's misreading of the ECG from a junior GP. That's why we need, and there's some misdiagnosed cases, they just discharge and goes home and suddenly they get attack. That's why we need to focus on the remote area and peripheral areas, and we need also to focus on the CPD. Now we have the bylaws, and the bylaws of the relicensure of the license will be effective and take role and action on the 1st of January 26. Therefore, we should also focus and concentrate on issues that raise the awareness and the competences of our staff everywhere. I already wrote a formal letter from the Jordanian Nursing Council to the Minister of Higher Education to mandate basic life support for all health college graduating to be mandatory, and it's already now take role, and they start to have it as a HAHA basic life support. Community awareness is very important. Therefore, we need the college and nursing college and medicine, faculty of medicine in all the universities across Jordan to take part. It's important that they should at least, the community, the university community, they should at least raise their awareness about the chest pain. That's all. And finally, we need one of your recommendations to have a national action plan.
Yes, that's the idea.
This action plan should include a standardized protocol and should be distributed across the country that help all the staff and training. Thank you.
Thank you so much. And actually, one of the suggestions of Dr. Hadi, actually, who's going to speak in a minute, was to create some sort of an app where we could upload those ECGs that you were mentioning, and one cardiologist can cover that application a day amongst 180 cardiologists. You get it once or twice a year. That's not bad. We're all willing to do that. But go ahead, Dr. Hadi.
Yeah, thank you for reminding me that we said that in our preparations, that if we have an app for people to consultate us on EKG interpretation nationwide, which is simple. I mean, we can do that. But out of courtesy, I wanted to talk, but my friend next to me, Abdul Zubairi, he is from Abu Dhabi. No. Allow me to give him the chance to do it, and I will give my comment.
Thank you. First, thanks for the invitation. I'm really enjoying the discussion here, and I'm learning a lot. These discussions on all the challenges that we talked since the start, we faced it throughout. I would say it's a journey for us because we started this work 10 years back, and definitely not going to be able to solve all the problems in one session. So this is a journey. The way I would look at it is just prioritizing those all the points that are presented and presented on our committees, Dr. Suresh, and prioritize it and solve it. But one of the things I felt made a difference with us today, for example, in Abu Dhabi, the penetration of primary PCI is about 95%, even more. Few patients in the one area that will get thrombolyzed. Otherwise, almost 95% of the patients that they get a primary PCI. And one of the key things was the governance of this effort. So we have an empowered group that involves all the stakeholders, and we meet regularly, we meet monthly, and we get data. So all the decisions are based on data. That is, like the door-to ECG, the transfer times, and all of that is auditable. So, so no one can make up numbers. So we have the audit team out of the Department of Health can go to the hospitals and verify what's the ECG time, what's the door time, standardization of all those data points, like the door time in our hospital is the same as the door time in another hospital, because we noticed at the start, some places they would have their door time as a triage versus another place they would have it as the time the patient enters the door and so on and so forth. So we standardized all the metrics and we track it, and that governance structure, would look at it monthly, and we hold people accountable. And when we mean accountable, not in a punitive way, but in kind of positive feedback, like we have the gaps, like, these patients did not meet, and so on. So I think governance is very important. Empowered governance that involves all the stakeholders and data. You know, without data, you cannot drive change. You will not know the problems. Like now, we're just discussing. You know, is this a 24/7 site or not? We don't know if it's 24 site. And what's the definition of a receiving center? You know, so if you say this is a receiving site or a primary PCI site, you got to meet the criteria. Someone has to go and evaluate and assess that site. Does it have, you know, proper cath lab? Does it have, you know, all the published criteria for what is a 24/7? So I think that, you know, this is an ongoing effort, and I would like to congratulate you guys for, you know, for starting. It's a great thing.
Thank you. Excuse me, colleagues.
Dr. Hadi.
Dr. Hadi.
That will not be long.
Then we'll move on, yes.
I have to make it very short. I think I just want to stress the point of public education before it passes by easily, because I think that's very important.
Yeah.
We have to find a way together as a team, to social media, the national TV. We can standardize a video, a simple video, which you can see when you land at the airport in the Queen Ali Airport. You can see it in the corridors everywhere, which can actually enhance the public awareness, like what my friend said.
Especially it's the first chain of survival. That's we are first in fact with people.
Exactly. And I think, I don't want it to pass like lightly.
No.
The other thing, I have to admit, يعني فعلتم طريقة، أنت بتعمل طريقة بجد.
وأنا بفرق بها جميعا هذا الموضوع.
فعلتم طريقة على الcivil services. What you're doing is really very true. Allah يخليك. Let me tell you something from our practice in the private sector, where sometimes things become a bit challenging for you. If somebody calls you from wherever, Sharq Amman, Gharb Amman, and they have chest pain, 911, they come in, the Madiaf says, well, the closest hospital is, say, whatever, there. I think the Madiaf has to also give the chance to that particular patient and family to choose if they want to choose another institution which is capable and within a distance, is to have them do it. Why am I telling you? Why am I telling you this? We are in the private practice, and I know how it goes. All what it takes, a couple of patients who will say, oh my gosh, أنا حكيت مع 911 وودوني على المستشفى الفلاني وأنا دكتوري بوحش عليه وأنا بدي you know, you don't want to go through that. Yeah, I agree. So it's إنقاذ الحياة, but at the same time, to keep that particular option open.
For the sake of time,
sure.
Thank you, Dr. Hadi. Basha, تفضل.
الله يمسيكم خير. أكيد أنا تحت العربي أنتم مبدعين. تسلم. شهادة أعتز فيها عميد الأطباء. Civil defense is a great job. The ambulances are well equipped and the staff are well trained and educated. I know this fact for a long time. Thanks. الله يعطيك العافية. مشكور باشا. أنا أعتز فيها يعني كان على صدر Our roundtable meeting is excellent, and definitely at the end we agree to standardize protocol. But I personally have no problem, which is the troponin and the ER.
Yes, which type?
This is a great problem. I commend Dr. Hadi today with his lecture. He gave us an excellent lecture on troponin, how to explain it. Different companies have different levels. And really, today I had a patient from Zambia, 19-year-old, having pneumonia and hemoptysis. They did troponin, they referred him to me. Yeah, and now when you tell the insurance companies troponin is positive, they don't refuse it. And you admit him. I listed for our residents more than 15 causes, non-cardiac, elevating the troponin. I don't know, they emphasize the troponin. If you have non-anginal pain, costochondric, pricking pain, even if you sneeze and get something, you will do a troponin. It's true. So I don't know how to solve this problem with our ER residents. Really.
Education. I think education.
And thank you.
Thank you. Please go ahead.
Okay, thanks for giving me this opportunity to be here, part of this human scientific conference. Thanks indeed. I'm talking here on behalf of the insurance sector. I don't know how's the management of this discussion, but I have a lot of takeaways and recommendations. Open the availability of the time. I mean, otherwise,
go ahead. Please.
Otherwise,
we do cherish your opinion, and we don't want to listen to it.
No, it's okay. But just I want to comment over two points from Dr. Mustafa and Dr. Yusuf. I'm honored to be part again among all of these big names. But I want to say that I do feel from my discussions during the sessions and this discussion that there is a prior wrong impression regarding the insurance coverage. It's not the case. Most of the cases are covered, especially these emergency cases. Maybe some of the elective treatments need some of the investigation from the approval section in the departments, but the emergency cases, the cardiac cases, it's covered. And if it's not covered by some of the companies, it should be covered without any waiting periods, without any executions.
Unfortunately, a lot of the private hospitals feel very uncomfortable to actually put a stent in a patient because they've been bitten before, where they go ahead, do the STEMI and put a stent, and then for some reason they get a rejection, and then they can't do anything, and it's a big expense. So that is a problem. If it's a STEMI, it's a STEMI. It has to go green light.
And again, the medical protocols are not, it's not there. So we have made big efforts just to be on the table. But till the moment, it depends on personal judgments. We heard this morning that there's something on the pipeline.
Yes.
Hopefully, we'll see it soon.
Yes. So
Thank
you. And hopefully, if we do have that guideline, then we would have your advocacy that STEMIs are kind of streamlined and they don't have to, get the pre-approval, because that would help a lot and that would save lives.
And I'll tell you something. Sorry for the interruption. Now we are going from the automation to the digital transformation, which means that more than 95% of the approvals will be given by the roll engine. So there is no human interfere. So the existence of the medical protocol is very essential, just to avoid any confusion or conflicts.
That's a good answer. Thank you.
معلش عايز شوية بس about the insurance. I'm in the presence of the president of the Jordan Insurance Federation. I would like to mention some insurance-related challenges in STEMI, emergency care. The first one is are the delays in approval. Many insurance companies require pre-authorization or administrative approvals before covering emergency interventions like PCI, which can significantly delay time-sensitive care. Besides, there is a lack of clear emergency protocols in the insurance that we need to verify, and after this conference, we have to work together for that purpose, actually. Besides, we need to know about non-recognition of golden hour urgency, because some insurances do not recognize STEMI as golden hour emergency, requiring immediate full service activation without delay, which contradicts international standards in STEMI care. Thank you.
Thank you. Oh, you answer, of course.
بدي احكي في بالعربي معلش مشان ما نوصل ننشر غسيلنا. انتم شركات التامين حقيقه كويسين زي ما قلت، بس الاطباء اللي عندكم هم يوفروا عليكم مش علي كيف، ولهم بونص لما توفر عليهم، فلذلك بعدين مش كلهم متخصصين نسائيه واطفال وباطنيه وقلب وعظام وكل شيء، يعني تعرف كيف هم جنرال بس شيء. احنا تدرس تعمل قسطره السي بي دي بتدخل ستنت بدل موافقه. ليش؟ طيب رسم لي الرسمه واي شيء وبعث لي اياه، صور لي الرسمه. بعدين اليوم مجاز ما بقدر يجاوب، استنى عليه، المريض يكون عطاله مرات التشست بين. طيب بس اوامر لما تكون كونسلتنت معروف ما يعرفوا يعني يتعاملوا مع ناس مع اطباء معتمدين وبيجي الجواب منهم ويعني يخففوا شوي يعني اذا
لا بس دكتور معلش احكي بالعربي يعني. طبعا انا بحكي الدكتور يوسف ما احكي بالعربي انا بالعربي لا بقول لما الدكتور يوسف بيحكي ما لا انت بالعربي دكتور بس انا اللي بدي اقول لا انت دكتور يعني قامة كبيرة. اللي بدي اقوله انه اليوم وزارة الاقتصاد الرقمي والبنك المركزي الاردني as regulator to the insurance sector واتحاد التامين في باك بروجكت هلا بالتعاون مع حكيم او EHS اللي هو الاي كليمز. هلا احنا في ترانسنت فيز اللي هو الاوتوميشن، بعدين رح نروح باتجاه الديجيتال ترانسفورميشن. اليوم بس حاب احكي هاي مهمه. اليوم مثلا الاوت بيشنت التيرن اراوند تايم اتس 2 minutes، اذا ما كان في ابروفل معناته ابروفل. هذا باي ذا سنترال بانك اوف جوردن and it's obligatory and كل الشركات يعني committed لهذا regulation يعني. فبس اليوم الاوت ممكن يكون في عليه شغله ثانيه، انه موضوع التريتمنت مش ريليتد للكفرج. يعني بدي افترض جدلا واحد عنده اكسكلوجن وجاي مثلا في اكيوت ام اي مثلا، اليوم موضوع الكفرج موجود او مش موجود مش مرتبط. يعني موظف التامين ما بيقول للدكتور عالج او ما تعالج، بقول له مغطى او مش مغطى. بس انا ما بدي ادخل بنفس الموضوع.
معلش بس دقيقتين فعلا خلينا نحكي بالعربي مشان الواحد ياخذ راحته وما يوقف فكره. احنا عارفين وين الديفكت، احنا كلنا عارفين وين الديفكت، يعني ما عندنا مشكله بقراءه التخطيط من اولها. يعني هاي المشكله بسيطه، يعني في عندنا ما شاء الله الدفاع المدني يعني ملتزمين وعم بيوصلوا المريض باقصى من الستاندرد العالمي، عم بيوصلوا لك اياه للمستشفى. المشكله بالمستشفى، المشكله انه المريض بوصل للمستشفى مش عمال ياخذ الرايت كير، اما انه فقير ما مع حق الثرومبولايسيس او الستنت، او انه عمال يوصل على منطقه فيها PCI بس ما بيشتغلوش الا بالرش اورز وبياخذ الثرومبولايسيس بعد الدور، او انه بيتاخروا عليه شركه التامين حتى انه يعني الكل عم بيقوم بواجبه وعم نوصل للمستشفى بس مش عمال ياخذ الرايت كير. هاي هي المأساة.
هو اقصد الدكتور مصطفى انه المشكله مركبه، احيانا من التامين واحيانا من اصحاب المستشفيات. فور فاينانشال هاي في ناس مساكين الحل،
في ناس مساكين مش عم ياخذوا البروبر كير اللي احنا كلنا بنحكي عنه، واحنا كلنا بنعرف المثالي وكلنا بنعرف الجايد لاينز وكلنا بنحكي فيها، واي واحد هلا يعطي محاضره بيحكي نفس الكلام نفس المصطلح يوصل للمستشفى بس مش عمال ياخذ.
Let's move on. Thank you, Dr. Mustafa. Dr. Anas?
Again, I want to emphasize the point that Dr. Najib mentioned. Thank you. I'm not sure. So that again, all of the problem is governance. First of all, so if we have this strong governance, leadership of that. It's a public health governance, a policy governance that is linked to finance. So again, I want this advocacy to support that the availability of secured fund, to secure the fund available, wanted to cover the stint, Haya stint, because it's so expensive. Another thing related to data, I want to highlight something we have experience at the NCD Directorate related to maternal mortality data and to record exactly every cause of death of maternal mortality and the causes of delays that happens. Delay to seek treatment, delay to start treatment, delay to come to the hospital, etc. So there are several delays. And I think that the presentation that Dr. Suraj presented, I think is very important. Thank you so much. And we can build on it, a very important system to track these MIs over the next subsequent months, and then to collect data and to have specific strategies to most important delays and causes of mortality or morbidity. Thank you so much.
Perfect, thank you so much. All right, to wrap up exactly. So I'm going to go, Dr. Raed, anything on emergency department that you want to add? Can I, Mike, please.
So on the level of the emergency, a simplified algorithm stating it very clear in a very simple way that everybody will understand what to do in ST elevation MI, period.
Agreed. All right, on hospitalization, Dr. Muhannad. Can we give him please?
2 points: to have a standardized protocol for treatment of STEMI pathway and non-ST ACS pathway. They have to be standardized and they're partly clear. We have to improve our ST elevation or PCI network. And what I think that what civil defense have this kind of register to follow up the cases, we need a nationwide register for the ACS patients. Not just those in the civil defense, but what happens with them after there.
Registry afterwards, absolutely. And as far as post-discharge, I agree also with the point that Dr. Suresh made. It is actually the journey is not just a cath lab, it is how the patient is treated before and after in a standardized manner. So we do need to make sure that they're discharged on the right medicines and maybe think of cardiac rehab centers in the future and medication compliance. That's it. Any further comments or recommendations? Dr.
I would just, Dr. Suresh mentioned something about,
Thank you very much. Dr. Suresh mentioned something about how to start a system of care for the whole kingdom. And I like the way he put it. I would suggest that our pilot first thing to do, which is probably the easiest part to do, is to start in Amman. Because the system, most of it is already on it. And you just have to polish and do things to standardize it. And once you do that in months to come, then you spread it, like you say, to the next stage and then the next stage, so that you include the whole kingdom within whatever, 12-month time or something like that.
I think, yes, the idea is to put a plan for the next year, and that plan will be in stages, which could be that. And we're going to work all on that collectively to get there. And yeah, probably we should.
You could have initially a first set of pilot hospitals that you can choose, like 5 pilot hospitals in Amman and its vicinity, and then those 5 pilot hospitals will collect the data. The Ministry of Health, all the people in JCS, all of you can work towards the 5 pilot data. Then you will review the 5 pilots. You'll change if you need to change something a little bit. After you do the 5 pilots, then you'll say, okay, now within Amman, how many other hospitals are there? Why don't we take the 5 pilots now and add 10 more hospitals? Then you say, okay, now in Amman and the vicinity, this is the standard of care. Then you go outside of Amman, and then you say you divide the whole kingdom into 3 or 4 phases, and then you create in each phase, you take it one after another, and then you can compare the You got to have a group of hospitals in Amman which all do the same thing. You compare that data, then you take it outside. So those are some suggestions that all of you can work towards. But thank you.
Thank you, really appreciate it.
بس دي جزء معلومة يعرفوها بس حابب أكد عليها إنه يعني as a note that our services are free of charge, okay, compared with around countries, because civil defense is a gift of His Majesty to the citizens.
True, that is correct, yes. Actually, an EMS charge just to come and pick you up from home is $700 usually, you know? So it's free. All right. Thank you, everyone, really, for all your efforts. It's been a long day, I know, but you've all done amazingly. شكرا كثير، يعطيكم ألف عافية وبارك الله فيكم. Thanks, everyone. Thank you, Dr. Suresh. Really appreciate it.
Thank you. Thanks, everyone. Have a great evening, and hopefully we'll meet soon at the Kingdom. So thank you.
Thank you, and thank you, Dr. Josh. Appreciate it.
Thank you.
Thank you very much for having us.